I invite Anand Ambali, and who is emerging as one of the important faculty in the geriatric profession, and he has a passion, and with that the BLD has been now recognized well as far as the geriatric department is concerned, and he is going to talk on geriatric practice. Anand, yeah, approach to the emergencies in geriatrics.
Respected Chairperson, Sir, Dr. Kotewale, Sir, respected Vice President, Dr. Rajesh Onodigi, Sir, Narayan Swamy, Sir, Secretary, all the respected dignitaries of the Association Physician of India, Karnataka Chapter, and invited faculties and my mentor, Dr. Sharma, Sir, and my dear students. A very good evening to all. At the outset, I thank Association of Physician of India, Karnataka Chapter for giving me this privileged opportunity to share my views on how to approach an older person in emergency department. And as our Vice President rightly mentioned, that we have this privilege because of the virtual classes, and we take this as a privilege from B M Patel Medical College as well. I bring greetings to you from the Geriatric Clinic of BLD Deemed University, Sri B M Patel Medical College Hospital and Research Center, Vijaypura. Now what happens is, all over the world, the studies regarding the admissions of older people in emergency department have shown that 57% of the patients belongs to the surgical conditions, while 43% belongs to the medical conditions. What is interesting to notice is among the 57% of surgical conditions, the mortality rate is 17 to 18%, while medical admissions are less. The mortality rate is around 23 to 24%. The patients admitted with medical conditions have higher mortality than those of our surgical conditions. This discussion is meant to help our residents to get the insight in providing care for the older people in emergency department. I hope all of you, all the senior members agree that our emergency units are getting aged or are getting aging, because most of the cases in emergency units are older people above 60 years. And the discussion also should help the experience in the emergency department, especially for residents, the clinician, the older people, and the caregivers should be less stressful. And most importantly, the attitude of care should not replace the technology of care. Instead, we can take the help of the technology, but it should not replace our attitude and the care that we provide to the older people. This is an old lady who has come to our institute in an emergency department, and just looking at her, look at what all she was put on. It's a navy, the blood pressure cuff, the ECG cables, the rope she was tied, the SpO2 monitor that she had, a Riles tube, or there's a Foley's catheter. So in an emergency setup, when an old lady, we require to use the technology and the assistance that is required to save their life. But what is more to be seen from a clinician, especially a geriatrician, what we see in her eyes. This lady had tears because she was in pain, and that was the only thing that conveyed to us through her eyes were the tears in her eyes. A patient was referred to our hospital who was a 78-year-old. He was brought to the ED department in another hospital at around 10 a.m. and he had an acute exacerbation of chronic obstructive pulmonary disease with history of fall. He was seen by a medicine resident in another hospital. He had advised ECG and a chest X-ray, and the patient was shifted to a radiology unit. Then again, a reference was sought from an orthopedic surgeon. So he advised X-ray for pelvis, AP view. Again, the patient was lifted. He was shifted to a radiologist, again brought back to the casualty in their hospital. Again, because he had a head injury, a neurosurgeon was called in. Again, when he came, he advised CT scan of the head. And this is what happened for the older patient in most of the hospitals, where they are brought to shifted to a radiology unit to come back to the casualty, again shifted to the. So till 3 p.m. the patient was on the transfer mode in that hospital, and because they were not happy, so they came to our institute. So this is how the older people face hardship in an emergency department. So this discussion, I like to take the principles what our residents can follow to give a better care for the older people. As we all are aware, the older people, that are 60 years and above, constitute highest admission rates in an emergency department. And assessing the older people in emergency department should be an opportunity for all of us to find what has been missing so far in many of the institutes where they were earlier admitted or for repeated admissions. Repeated admissions need to be addressed or assessed for elder abuse, self-neglect, and depression. Most of the authors in the literature have defined repeated admissions as more than 4 to 6 admissions in a year for the same symptoms. We also come across the older people who reach us in the terminal stage of the disease, where we should, as a consultant or a physician, should think of allowing natural death or respect the terminal wishes of the patient. Most of the times, the past history, the previous records of the health may not be available every time the patient comes to the emergency department. So we need to have a good assessment at our hands. And the geriatric emergency care model training is lacking all over the world. As we all aware, the case record folders, best measured in kilograms rather than pages, commonly testify the numerous departments previously involved in the care of majority of older patients. And we see that most of the older patients, they carry a bag, 2 bags of files that they have been referred earlier and been seen by clinicians earlier. Now coming to the principles of the older patients assessment in elderly department, emergency department is, we know about triage, clinical assessment, and the discharge. So my discussion will concentrate on clinical assessment. So the clinician or the resident who is taking care of the older persons in emergency department should be able to have a shared decision making among his colleagues of different departments as well. We should focus on the risk and the benefits of therapy. Always we should consider the quality of life for the older people that we are going to give within the hospital and after the discharge. Interdisciplinary care should be priority, and the 2 main important things a clinician must do is to avoid an iatrogenic harm. We should not use a polypharmacy, and we can even avoid the drugs which would not help him. And the most important thing is we need to avoid another disability as far as his diseases are concerned. So for all these things, the time and resource management is very, very important, because one patient admitted in emergency department, it takes minimum 45 minutes to 1 hour for the things to settle, and then it is to be shifted to the intensive care unit as required. The pattern of disease that occurs in the older people, most of the common diseases that they come across emergency departments are acute onset, maybe infections, exacerbations or relapses of the existing diseases, hyper, either glycemia or hypertension, electrolyte disturbances, vascular disturbances like ischemic heart disease, stroke, intracerebral bleed, neurological disturbances already having degenerative diseases like Parkinsonism or Alzheimer's, and they develop complications, and of course musculoskeletal diseases. Along with this, in acute onset presentation, they will have multiple comorbidities. So this is a challenge. The residents in medicine who are going to face the older people in emergency department have to face these challenges along with an acute onset diseases. So all these comorbidities overlap and present challenges for a treating clinician. So the resident should be able to do a multidisciplinary and a multidimensional assessment in a short time. So that comes by experience. He should be able to identify atypical symptoms, that is very, very common in the older people. Silent symptoms, most of the times myocardial infarctions are silent in diabetes and they present just to the breathlessness as a complication of a myocardial infarction. Disabilities has to be identified so that we will prevent another disability. Cognitive impairment has to be monitored. We have to assess the functional impairment that he had because of the disease process. Most importantly, we have to concentrate on the medications that the older person has been taking off record and on the records, and history of trauma and falls has to be assessed. Simultaneously, We should be capable to initiate a palliative care, allow natural death, and start conversation regarding end-of-life care. All these things should be analyzed, and we should be capable to initiate in a given patient depends upon the condition it demands. So how do we approach an older person in emergency department? We take the history from the patient or the family members or the caregivers. Most of the times, we have to address issues like anxiety, fear, and depressions. Most of the older people, the moment they come to the emergency department, they just pray and beg us that please don't admit immediately. So first, let me give me some time. They take more time to give a permission for their admissions. And the past history is longer than the present history. The caregiver and family members may or may not accompany. Sometimes, most of the times, it is the neighbor that come in the midnight. We need to contact the family physician who was treating him earlier so that we'll come to know the important points that he had in health-wise. If there is a previous discharge summary, we must go through it. And of course, we should involve the patient and the family members in decision-making in whatever modality of treatment you like to give for the patient. Again, the older persons who are staying alone, we don't get the proper history, and we don't know whether he had a medication compliance in the home. These are all put under question. Most of the times we saw that neighbors accompany the older man, and he may not give consent for investigations till the relatives arrive. And even the family members are there. The history of fall in the bedroom or the bathroom is not reported. Either it is not seen or it is purposely concealed by the caregivers. If the patient had a seizure, most of the time patient attenders not have seen or not reported by the family members. And abuse, the patients who are neglected, the history is avoided by the caregivers. So once the patient comes in the emergency department, what we should look for? We should look for vital signs. We all know the two more important vital signs added to the pulse, respiratory rate, temperature, and respiratory rate is blood pressure, is pain and the delirium. So these two are the added vital signs to be assessed in the older persons. Of course, nowadays we are checking the saturation, look for the anemia, jaundice, and dehydration. This is very important. Dehydration has to be assessed. Involuntary movements, pupils, plantar, and signs of injury. This should be a quick assessment, should hardly take a few minutes. And of course, respiratory system examination, cardiovascular, per abdomen, muscular system examination should be carried simultaneously for this. And meantime, depending upon the condition of the patient, if he is in respiratory distress or is in coma, you can start oxygen, get an GRBS done, and if it is hypoglycemia, immediately correct it, or hyperglycemia, immediately start the treatment. ECG should be taken immediately at the bedside and find that if there is any cardiac or vascular event. Bedside X-ray should be done immediately because we don't know whether the community acquired pneumonia patients can come with delirium. Injury part also should be assessed by the X-ray, and simultaneously we should send the blood for biochemical and pathological test, and immediately we should secure an IV line whenever the person is brought to an emergency department. We should also ask the patient attenders or the caregivers about the activity of daily living, instrumental activity of daily living before 1 week or before a day of admission to the emergency department. What are the challenges a resident can come across when he deals with an older person in an emergency department? So the older man can have a decreased hearing, reduced vision, he may be in delirious state, he may be depressed, he may have dementia, dehydrated, frailty is again important, sarcopenia, and the reduced functional capacity. All these poses challenges for a treating clinician in assessing the older person in an emergency department. We should all be aware regarding the geriatric giants. The 5 geriatric giants that like immobility, falls, incontinence, pressure sores, and confusion can all be a presenting features of the hidden disease. The fall may be a manifesting feature of a myocardial infarction. In confusion or delirium can be a presenting feature of pneumonia. These 5 geriatric giants were described by Isaacs in 1992, while the recent new generation geriatricians have now put another giant like iatrogenic disorders, where we as a clinician add because of the drugs that we can create another giant in them, polypharmacy. So I'll just share what are the do's and don'ts, what the clinician can practice in an emergency department. When we come across an older person in an emergency department, we should orient the person to that place, time, and who are all we taking care of him. Ensure that adequate hydration is maintained. A good communication is very, very important. Listen to him and give gestures that you are understanding what he's talking. Involve the team members. This is very, very important. Involving the residents, postgrad students, even the interns, nurses, social servants, all social people and the servants, all should be involved in taking care of the older people. And please plan to do all the investigations required in the same go. Plan it. Let it be a little half an hour late, but you should, once it is shifted to radiology unit, all the investigations required should be done in one go, or preferably in a bedside status. And of course, we should involve the caregivers and patient in decision-making process. And the don'ts, please avoid tying the older persons to the bed, and even that begets the delirium again. Putting the multiple tubes, unless it is required, of course, and should not restrict the patient meeting the family members. This is very important, because allow the older persons to meet their family members so that they can have a good rapport and they feel comfort, they feel secured in the hospital. Of late, there is a concept of geriatric friendly emergency departments. In many countries it is coming. We can even do in our own setup, depending upon the requirement and the facilities that are available in our own institute. So what we should do in an emergency department to make the older feel safe is that we can keep him warm. If he wants to have some coffee or tea, we can provide it as the emergency, or make comfortable. And if he wants to move around using the walker, he can be made. And he should not be left alone on the bed for a long time. And if we overlook these important needs, we can lead to the increased risk of delirium in an older person. Providing reclining chairs, this is very, very comfortable for the older people. Warming blankets. Privacy is very important. The older person, they feel that they're undignified when the privacy is not given to them. And in case if they are short of hearing, you can use voice amplification devices also. And the older person in emergency department, till you do a complete assessment and want to transfer to the intensive care unit, he should have an easy access to restrooms, availability of mobility aids and walkers for him to use the restrooms. So what has been found, that the older people are being tied to the bed for just to prevent a fall in the hospital and making them immobile, which further aggravates the existing diseases. And it has also been found that in our part of North Karnataka, we see that the older people, they first go to the faith healers where they have been treated with their bending marks and their hot iron rods are posted, and these people, they turn up with septicemia. And earlier there were round dots all over the body or along the nerve endings, but now they also have the faith healers have become new generation, like they are putting the scar marks that is seen on the right side of the photographs. We should be also aware that our emergency departments or intensive care units produce more noise and create noise pollution rather than the regular setup what we have. So we should avoid the monitors beeping around the clock even in the emergency department. And this is a lady who presented 80 years old female, history of fall, and the impact of the fall was so much that she had almost a hemorrhage on the upper eyelid, and she was still walking around, and on doing a CT scan, we found that there was a huge infarct in the temporal occipital area. So any patient, what we want to convey is, if they come with a fall and such an impact of injury is there, we should not miss diagnosis, and we should evaluate thoroughly before we send them home. And of course, again, as I mentioned you, we come across all types of patients in our emergency department. So this is a case of malignant growth, which has multiple ulcerative fungating growths, and whatever she used to drink used to come through that opening, and there were a lot of maggots. Hardly any attenders were able to be with her, and this is where we should initiate a palliative care. So emergency department is where we can think of variety of modalities of care that can be provided to the older persons. So with this discussion, I like to conclude that the complete process of evaluation and examination does not happen in one setup in emergency department. It takes a long time. most of the time the older person whom you go to meet and he just holds your hand, he doesn't leave it, he holds it for a long time and you have to just try to remove your hand. That happens with persons with dementia and those who are in failures. The process of evaluation of an older person in emergency department rewards speed. The time frame is immediate. We should be quick in assessing. Simultaneously, we should be quick in starting the immediate treatment, and focus is on the patient's complaint. And I like to emphasize that one size fits all will not be possible for all the patients, elderly patients coming to emergency department. That's why there has been no guideline from any of the authorities all over the world that how the emergency department we should handle the older persons. It depends upon their setup, the manpower that they're having, and the type of emergencies they're getting. And I request all the practitioners and the residents to say no to ageism. Don't discriminate the older people for treatment in emergency wards. And as the saying goes in the English, it's one has a hammer, one tends to look for nails. So unless because we have a lot of technological gadgets and assessments tools, so we try to use them, but we have to think when what benefits outweighs the benefits to the older person. We should always look at the preventing the or giving the good quality of life and of course a dignified death to the older person. And for all these things to happen in a short time in an emergency department, we need to have a team, and team works. So just to conclude, I quote Williamson, almost everything to do with the health of the elderly is a matter of urgency. If an older person is unwell on Monday, the chances are that he or she will be worse on Tuesday, and by the end of the week may be bedridden, dehydrated, confused, and incontinent, I unquote. So this statement, though quoted in 1978, still holds true that we should never deny or delay the management process in an older person when he visits the emergency departments. Thank you very much for this opportunity, privileged opportunity, and thank you for all your patience listening.
Thank you, Anand Ambali. It was comprehensively, you have given approach to the geriatric population. Though they look old, really they are not that old, but electrolytes, infections, and ICU psychosis is what commonly we come across in people who have no diseases. But diseases also do come because of vascular disease, degenerative diseases, and then malignancies are commonly coming. But even if they don't have anything, infections, electrolyte imbalances, and then some psychosis related to here and there will be seen frequently. We have the renowned the godfather, like a godfather and mentor for geriatrics, Dr. O.P. Sharma will conclude his remarks on this, so that we'll take care of all this.
Sir, at the outset, I would like to say that API Karnataka chapter is doing a wonderful job. I would also like to compliment Karnataka for one thing about which I couldn't make a remark earlier. That was about the vaccination. The first vaccine in the country was used in Karnataka only for Maharaja's family. The first Indian guidelines which have been made for older persons in the year 2008, the mentor have been Karnataka. I cannot forget Professor P. S. Shankar's contribution in the same. And both Vijayapura as well as Belgavi have got geriatric clinics, geriatric departments. That is again commendable. Professor Ambali, it's always a pleasure to listen to you. And what I can conclude from your talk is that to become a good geriatrician, one should be a good human being, a good clinician who depends on the clinical judgment. And what I teach during my ward rounds is that in the patient, try to see the image of your grandfather or grandmother, and your whole attitude will change. I think a clinical judgment is the key. Thank you so much for this opportunity.
Thank you, sir.
Thank you. since a lot of other people, because of I saw that Anita Basavaraj and other many have joined from Maharashtra and other things, and it is very nice that all have logged in. And since there are some chat boxes, questions are there, then if they are able to, I am asking there's who is monitoring that?
We are monitoring, sir, here.
Yeah. If any one or two important questions, because we are already.
No,
Then,
sir, we don't have any questions.
We don't. Since there are no other questions, then we to save the time and all the things. I am seeing that Dr. Chandrasekhar sir, who is a mentor for all of us, and because of him, our API has gone in such a discipline. And I have to quote this since many people have joined here. Namaskar, Chandrasekhar sir. Yeah, since there are no other questions and everything, I request our secretary to give the vote of thanks.
On behalf of APA Karnataka Chapter, I immensely thank our chairman, Dr. V.A. Kotiwale, for conducting today's virtual monthly clinical meeting. On behalf of APA Karnataka Chapter, I also thank BLD Deemed University, Sri B. M. Patil Medical College, Research Center and Hospital, Vijayapura, for hosting today's monthly clinical virtual meeting. I thank immensely the medicine department of Sri B. M. Patil Medical College Research Institute for hosting the today's meeting. The HOD, Professor and HOD, Dr. Sharan Badige, Dr. Rajesh Vanutigi, Professor of Medicine, and Dr. Anand Ambali, Professor of Geriatrics. I thank Professor Sharma sir for today's interactive virtual monthly clinical meeting. I thank all the presenters who presented all the cases, interesting cases in the virtual monthly clinical meeting. I thank all the senior professors. I thank all the faculty of BLD Deemed University. I thank all the honorable APA members. I thank one and all for today's virtual monthly clinical meeting. Thank you all. Next month, the virtual monthly clinical meeting will be hosted by Medicine Department, KIMS Hubballi, and details will be mailed later. Thank you one and all.
Thank you. Thank you so much. It was a pleasure to join it. It was a great learning session. Thank you, Karnataka API. Thank you.
Thank you, sir.
And my namaskar to Dr. Kotiwala sir.
Namaste, namaskar sir. We will definitely invite you for all the meetings, and it is our privilege. And I really sincerely thank all the members who have joined from Maharashtra, Delhi, and other places. Thank you very much, sir. Thank you.
And my respect to Professor Chandrasekhar sir.
Yeah, thank you.
क्या एक्टिंग कर रहा है उससे गवारा है खुद एक्टिंग कर रहा है सुभाष देव
Hello. Sir, Narayan Swami sir.
Thank you very much, sir. Dr.
Sir, thank you for giving us opportunity, and I also congratulate our postgraduate students and Dr. Anand Ambali for their excellent presentation. Again, once again, thank all the distinguished members who were present for this session and for their patient caring. Thank you, and also.
Thank you, sir.